everyone, I'm Ron Waxman. This is the COVID-19 series at CRT Online. And we are discussing today a very important topic that actually was surfaced again during the COVID-19 pandemic, racial disparities. We're all aware to that. I have really four friends and experts in the field, Dr. Kim Williams from Chicago, Dr. Wayne Batchelor from Virginia, Aaron Horne from Texas, and Sara from DC. Welcome, everybody.
Thank you for having us.
And maybe Dr. Williams, you can kind of set the stage, give us a little bit background. Where do you think we're standing right now with regards to racial disparity and the COVID-19?
So my introductory comments are really wrapped into the idea that we have more risk factors. And I can share my screen and show you a really sort of frightening picture. And let's see if I can share that. There it is. Wow. This is actually the last pandemic that we had in the United States. And we've actually been living in a pandemic, but we sort of have expected it, meaning cardiovascular disease kills over 600,000 Americans every year. The last time a disease, another disease killed over 600,000 Americans was the Spanish flu epidemic in 1918. It lasted for 3 years, but still it actually was, heart disease was back as #1. By 1919. Interestingly enough, we may not make it down to #2 because heart disease is still a pandemic affecting low and middle income countries, but coronavirus deaths are really may actually approach that level in the United States. We're obviously not done with it, and because we're doing the social distancing, it'll be quite a while before we understand the full impact. But what I wanted to focus on for the African-American community is that we have struggled with this. And there's so many sort of fingers being pointed at the Black community as to why it's happening. And I recall the words on CNN of my good friend Regina Benjamin saying, don't blame the victim. Well, I kind of would like to just say, what are the things that have led us down this path of, obviously it's multifactorial, it goes back decades, but there are some things that we could do even now to try and improve the outcomes in the African-American community. So just a handful of slides that will talk about them. One is we really should be doing the safe distancing. We've had these reports, particularly in Chicago, of people getting together, but it wasn't just Chicago. There was Mardi Gras, there was spring break, affecting a lot of different communities. But if you focus on the bottom half of that inset on my slide, there are a lot of EVS workers and public transportation, police, firefighters. They're people who are getting ill because they really don't have any other choice. Now it's affecting healthcare workers as well, and we know, and the mental health of each of these sets of individuals has become suspect, and we're really concerned about everyone who has to go out and can't do the social distancing. But in Chicago, we have flattened the curve out pretty well. And you see a lot of memes of our mayor actually really trying to enforce social distancing. And I think with some success. At Rush, we are seeing a lot of the patients because we were designed as a hospital for upsurging up to 175 intensive care unit beds. It was designed so that you could take a recovery room or a GI endoscopy suite and within 2 hours turn it into an intensive care unit. And that's been done. 175 unit beds is actually about 1/4 of the capacity of the entire state. And we have about 20% of all the cases in Chicago at Rush. But the impact on us and the entire world as well as the United States really needs to be evaluated in terms of who is vulnerable. Many people are getting coronavirus, such as the Icelandic study, where 50% of people who had evidence that they had the virus were actually asymptomatic. Didn't end up in a hospital, didn't even need to seek medical care. Well, that's not what we're seeing in the African-American community. And learning from what happened in China and Italy, it's very clear that if you have risk factors, such as diabetes, chronic lung disease, cardiovascular disease, you are going to be at higher risk for severe COVID-associated phenomena. And we've been talking for years about the African-American community, the Regards trial talking about the African-American eating pattern, what it does to us in terms of cardiovascular disease, hypertension, premature death, but also obesity. And if you look at everything that's going on, we really could be fighting this with nutrition. To focus on that, just a month ago, there was an analysis from New York where Judith Leiter actually looked at obesity as a risk factor for more severe illness. That is, being admitted to the hospital was much more frequent if you were obese, and if you were more moderately or severely obese, the numbers got even worse. So that the bottom right-hand corner, the hazard ratio of 3.6, if you had a body mass index of over 35, meant that you were much more likely to end up in an intensive care unit. What is really happening is that the younger patients, less than 60, are really at a lot of risk if they have the obesity feature. And that is unfortunately not evenly distributed between the Hispanic and the African-American community, with almost 80% of African-American women having obesity or being overweight. And so we're trying to learn more and more about why that is. And so just a couple weeks ago, there was a very insightful article that talked specifically about what is happening with adipose tissue. And it turns out, just to summarize it, that the adipose tissue has a lot of ACE2 receptors, which is the entry point for the COVID-19 virus. It actually is a target for replication, as well as immune activation, more viral shedding. And everyone's heard of, we're really worried about the cytokine storm that is taking people out. Well, it turns out that the adipokines, the cytokines within adipocytes and released from macrophages, is an extremely difficult problem for the patients who are obese. And so when you talk about, cardiovascular disease as a risk factor, and hypertension and diabetes, the question comes up, how much of this is actually correlated specifically with the obesity issue? And so we can actually look at this, statistically in retrospect, but what we really need to do is fix the things like nutrition, like lifestyle, that has led to the obesity epidemic in the United States, and particularly in the Black and Hispanic communities. In Chicago, we're doing really poorly. You can take a smaller percentage of the population and have the most deaths, as shown on these slides. And in Louisiana, it's New Orleans, and Michigan, it's mostly Detroit. And is wherever there's a lot of African Americans, you're seeing this death rate and this death disparity. So I would say that we have an opportunity to try to change this, and people think of that as a long-term strategy, but the nutrition interventions that people could do could actually start them on the way to weight loss now. One of my best friends actually called to tell me after her COVID that that the fact that I had hassled her mercilessly to lose weight probably helped her survive. And that really is the case. You can start now, and I would really try to spread that word of having much of a more healthy lifestyle. We're starting to see it in the news. Seeing Charles Barkley on CNN saying, we need to stop with the hamburgers and all of this stuff. That's really encouraging, but I'm not sure that the word is getting out. So I'm glad that you're putting this on, Ron, and hopefully everyone will take this nutrition thing that we've been talking about very seriously and very quickly.
Thank you very much for this insightful introduction, and always your focus on the diet, which I think is very important. But I want to maybe ask any of you who want to weigh into that. One of the issues is access to care, and we discuss it with other diseases. And I wonder, and maybe Aaron first, and then Wayne, how much do you think you see that mortality because the access to care or the time that patients are coming with their symptoms is delayed compared to the other population?
Thank you. I think this is a very important point you make, Ron, and I think it's multifactorial. One, And I think there was an interesting article published in Circulation just recently by Lisa Cooper, who's at Hopkins, Michelle Albert, who's the president of ABC, and Dr. Haynes, who I believe is at UPenn. And it looked at a lot of the larger policy implications that have in some ways potentially exacerbated the death toll. And we know that there still is a gap in terms of the trust component that doesn't always permeate African Americans, in particular interaction with the healthcare system. And that in some instances has delayed people's presentation. And the other piece, I really hope that, and I think that this is a great forum, that the communication surrounding the symptoms and how you go about seeking care needs to be streamlined a little bit more. I have a patient that presented to the hospital just this last week. However, she was afraid to go to the hospital and she was sick at home for 2 weeks and then expired shortly thereafter. And so, you know, I do think that it's important that we communicate effectively. And I think that there are certain, you know, ways in which we're trying to communicate better to African Americans in terms of the symptoms and how they would go about seeking care. But I think that that trust component still is very important. And this article in Circulation speaks about how you go about trying to improve that trust. And I think that a lot of this is institutional. And also, if you look at housing patterns, patients that are already in more populous areas and oftentimes live on top of each other. And then, you know, also you mentioned, Dr. Williams did about more telemedicine being used. And there's still some areas where there's socioeconomic differences where not all of these households of African Americans have access to those electronic communications as easily. You know, obviously we can think about using, you know, FaceTime and things on those lines, but I know in our institution, you know, we use a different type of system that I think is Halo. So I think we have to do a better job communicating, and appreciate this forum to try to improve that.
Wayne?
Well, you know, we're just scratching the surface of a really complicated issue. We know that healthcare outcomes related to race and ethnicity and even gender have been wrought with so many different influencing factors in the past. And I think COVID-19 just highlights this and amplifies it. It's a very lethal condition, especially if appropriate care is not undertaken. You know, we recognize that probably exposure is different, and it probably has something to do with some of the risk. There, as I think as Dr. Williams noted, African Americans and Hispanics are disproportionately involved in, you know, frontline work, essential work, things like food services, transportation, public transportation, healthcare. They're at the front lines of this, and so their exposure, their living conditions may be much more complicated. They're more likely to be in crowded living conditions and taking public transportation. So exposure may be a real phenomenon. And then on top of that, testing, there are huge disparate differences in testing based on race and ethnicity. So, you know, Dr. Williams probably is aware of this. In Illinois, 24% of all the COVID cases are African American, 38% of deaths are African American, and African Americans, of course, only constitute about 13% of the US population. So there's also a lost opportunity to detect the disease based on testing, access to testing. You touched on access to healthcare, and I think it's a very cogent point, Ron. You know, we showed in Platinum Diversity, where we looked at 1,501 minorities and women who underwent PCI, that actually one of the strongest independent predictors of outcome was actually whether you had access to commercial insurance. So these things are real and they're multifaceted. The last parting point I'd like to make is biology. We don't understand how biology plays into this. Kim Williams nicely spoke about obesity, and probably that's real and a real phenomenon. But there may be other factors. For example, the penetrance of hypertension in African Americans is huge. And one of the things that happens when you develop hypertension is you become depleted of L-arginine. Well, L-arginine is actually a really important factor in appropriate nitric oxide synthesis. So, you know, whether or not that has any impact, I don't know, but we're just scratching the surface. And because we haven't collected data, we don't have much data to go on. It's only been over the last 3 weeks since there's been a lot more pressure to collect data based on race, ethnicity, and access to testing. We still have a long ways to go, and we're just scratching the surface on biology, because I think we don't know if there are other genetic or biological factors that are at play.
And we may go back to the science later on. I'd like to ask Sara, I mean, you're very much involved in the community and engage with patients. If you can share with us, what is their reaction? What do they feel about the whole issue? I mean, you take care of minorities and African Americans and Latinos, and they hear it in the news or read it in the paper that they're at a higher risk. I mean, how they do react to the day-to-day news, and what is your day-to-day impression? And are you trying to do any telehealth? I mean, share with us what is that your experience tells you.
Sure. I'd like to piggyback on what Drs. Horne and Batchelor said, in that the combination of poor health literacy, traditionally, lack of access to health insurance, lack of access to good quality health care, combined with a general mistrust of a healthcare system that has notoriously failed the Black community for a lot of different reasons, implicit bias that is baked into our healthcare landscape. We all know the history of how racial disparities have come about, and a lot of that has to do with just the way Black people have been treated in the healthcare system to begin with. It's part of the design. So I see a wide variety of patients, all types of different socioeconomic statuses that are all Black people. So we have, very well-to-do to not so well-to-do with all different types of insurance. And there's not a lot of commonality apart from the disease burden. The disparities in healthcare have represented themselves in a notoriously large burden of cardiovascular disease, which really puts us at a disadvantage to begin with. But the health literacy in my population is so variable that the patients who are less health literate are much less likely to trust the information receiving from the outside. And unfortunately, there's a gaping hole in the leadership and the messaging on COVID in this country. Since there really is no federal involvement, it's become quite hyper-regional. And small regions, hospitals, communities are left to fend for themselves. So our patients are really looking to us for guidance, and they're looking to us for a cogent, sound message. They're really not trying to wing it. I've apart from my practice, the sort of rumblings that I hear on the street and in our friend circles are far more wrought with conspiracy theories. You see these protests that are happening at a lot of these state capitals, and that's a whole nother political conversation. But really, my interaction is very similar to my interaction with my patients as it relates to COVID-19 is very similar to my relationship with them in general, which is teaching them the facts, arming them with the data, and in general, it's been well received as a result.
Yeah, I mean, we have been at CRT and other forums have been always conferencing and discussing about racial disparities in the cardiac arena. So it's not something new for all of us. I mean, we are aware to that. It struck me that for many people, they came with a big surprise. The question here is twofold. First of all, maybe there will be more tension now to close some of the gap because you needed something to shake everybody else, they not take it. But the thing is also that worries me is when you need to come back from the pandemic, and as patients still are dying more from diseases not related to COVID-19. And that's also very prevalent in the African-American community and minorities. How do you bring them, you talked about trust, now you have to bring them to a trust to come to the clinic, to come back to the hospital with the fear not to get infected from the COVID-19. So Aaron, you want to relate to that? I mean, how do you deal with your patients? How do you schedule them right now when you know that there is still patients in the Texas area with COVID-19?
Yes, so so when this first started about 4 to 6 weeks ago, we went to entire telemedicine, and that was not just for patient protection, but also protection of our staff. And so now I'm about, I would say 70% back seeing patients in the office, but it's still a very interesting process. You know, patients are still very uncomfortable even coming into the office setting, and Many of them are trying to wear masks and wearing gloves, and you know, the physician-patient relationship is one that often, you know, obviously requires you touching your patients and you being able to make sure that they're comfortable with that process as well. So it is an individualized basis, and I think that the trust component is real. We are, I think Sarah's point is very important in terms of the inconsistency of messaging. You know, here in Texas, we just had, you know, a woman entrepreneur who owns a beauty salon decided to reopen, even though there are obviously certain criteria that states were urged to consider first. That person was sent to jail by the judge, and I believe that that is being overturned. And so when you have an inconsistency in terms of not knowing what and how you should protect yourself, and then you're being told you should protect yourself by doing certain things, but then people aren't held accountable to living up to that, you know, that's sort of a dangerous barometer that we, I think, are at right now. But in terms of the trust component, getting back to, you know, how do we overcome this? That's why I'm proud to be a member of the Association of Black Cardiologists. I think it's our role in working with partners such as yourself, who also is obviously a partner of the ABC, and making sure that we are doing a better job of messaging. You know, I think that the African-American patient population, while obviously not monolithic, are very good consumers if they can get the right information. And, you know, they obviously, you know, want to protect themselves and their families. And so, you know, I think that this is in a very important forum so we can improve that messaging in particular.
Dr. Williams, you are past president of the American College of Cardiology. You dealt a lot with societies. You probably interact with other societies during your time when you served as a president. Who should take the lead on that? I mean, we can do and maybe add a little bit more through those website and meeting, but it looks like we are missing a more higher level leadership. You know, even in the task force, I mean, you look, who are the people that really talking to the African American? If they are very vulnerable, who is going to make a decision that maybe they should be prioritized to be tested when testing is available everywhere? I mean, what can you suggest us with your experience on this role?
Well, I know that in Chicago, there has been a focus on trying to get more testing out to the smaller community hospitals that has been successful. And that's why we're actually seeing numbers go up. The numbers may not actually be going up, but they are the cases that we're recognizing are going up because the testing is being done more so. Now, does it take an African-American mayor to have that happen in a city like Chicago? You know, and so that there is a focus on the people who are dying. I'm sure that New York is similarly really pushing out to the people who are at risk. It is easier for me to talk about the inward-facing issues, you know, that is, we should control our diet and all this stuff. But the outward-facing issues we've dealt with, we've been talking about healthcare disparities and healthcare inequities, and there's so many aspects of it. The fact that our education system is poor, which means that we end up in an EVS job instead of, you know, being a lawyer or a physician sometimes. And so these are the kinds of things that are going to take a full-fledged effort by every aspect. So to me, your question's a great one, Ron, but I would flip it around. I'm not saying which agency, I'm saying all of the above. That is, this should be all hands on all decks to turn around 400 years of disparity that is playing out in a way that hurts everybody. I mean, do you think that the wealth of the Black community, by the way, one of my favorite healthcare financing points, do you think the wealth of the Black community can handle all of the sickness that's happening in the Black community with COVID? Of course not. Who's paying for it? And so it's you know, as long as we are a society, as long as we are a country, as long as we have EMTALA, the Emergency Labor and Treatment Act, it's in the best financial interest of everyone to fix these problems. So I'm hoping that that every aspect of government and every, you know, everything from a church to healthcare institutions, everyone sets up programs to try to get recognize and uproot every single aspect of healthcare inequities, and take this as an opportunity to make us all better.
Thank you. And I'd like maybe to follow with the question related back to the science with you. Most of the patients that we see actually dying from the cytokine storm, and that's irrespective to gender. I mean, obviously, is there anything there that you can relay? You mentioned a lot about diet and immunology, but is there anything else that you can see why someone would be more vulnerable to the cytokine storm versus others?
Right. I think it really is just a matter of degree. That is, if you have the kinds of tissues that allow for more viral replication, then you're going to get a stronger reaction. And this is, it's not unheard of. I know that the CDC a few years ago published their results of the frozen Spanish flu virus, and how in primates it was incredibly inflammatory response inducing. And we're seeing the same sort of thing now. Only thing we can do is continue the clinical trials, the remdesivir, everything and the supportive care. We are concerned, but though, we always talk about trying to, turn off the faucet instead of mopping up the floor, but there's a lot of floor to be mopped here. And when our inner city smaller hospitals don't have the intensivists and they don't have the ability to prone someone when they're critically ill to optimize their ventilation, then part of our strategy has to be move them out. And we've been doing that at Rush, but that needs to happen everywhere. Recognition that these people are really critical, and we're not going to just, okay, no more DNRs, which I've heard at several places, no more resuscitation. This is the time to really take advantage of the fact that we're all interconnected and we can transfer people to higher levels of care.
Thank you. And maybe when you're in Virginia, and I think I heard your governor already open elective procedures. I don't know if this is happening. So can you share with us if it's really happening? And do you see now, when you started to schedule your elective patients, some disparities in the patients that are coming right now versus those who may come later?
So first of all, there's a little bit of a lag phase between when Governor Northam opened up the state last Friday and what we're actually doing now. We're starting to see an uptick now, but because we're trying to do as much testing as we can feasibly accomplish in these patients who are needing procedures, I think next week we'll see a bigger uptick. We are seeing a modest increase over the last week. What I'm personally experiencing is patient concern and fear, in addition to healthcare provider and physician concern and fear. And unfortunately, we're in this really odd state where we can't test 100% of patients coming in for procedures. We have an algorithm for that. And we also can't don N95 or what we consider appropriate PPE in all cases. So there's this challenge where we're having to make difficult decisions. And so in order for us to feel safe, for our patients to feel safe, I think we're going to have to strike that balance between more universal testing and also the ability to don N95 masks and all the rest of the PPE appropriately, because patient concern is a real thing. It's just too early to tell for me to have a sensible answer to disparities related to race and ethnicity on the surge, but I'm sure it's going to play out, Ron, both with regards to fear, access, capacity. And just on the testing issue, there's a huge gap on testing. And so we have a lot of Hispanic and African American. And by the way, American Indians and Alaskan Natives also face the same disparities, if anything, maybe even more. This virus is sitting in those communities, replicating and being passed on to others because we're not probably quarantining as much as we'd like. So I think the recovery is going to be a challenge, and there's again not so much federal leadership on that end, and states are sort of left to their own decision making. And then on top of that, I don't think that the opening of states is necessarily correlating with the universal availability of testing kits, especially nasopharyngeal swab availability and reagent availability, and also PPE donning that's considered appropriate. So it's an imperfect situation that we're in, Ron, and I think it's going to continue like this for several weeks.
Thank you. And maybe Sara, we know that with every challenges and crisis, there are some opportunities. So maybe you'll share with us what type of opportunities you see that we can take from this crisis that would make us better in the nearest future.
And I think the fact that we're having this conversation, and we're having this conversation frequently, and this topic has persisted through multiple news cycles, is a sign that the country is being educated on the issues that we all hold very near and dear and take on as on a daily basis. So just the fact that the country is now aware of what we're all going through and what our communities are going through is an incredible opportunity. Some of the ways that I see this working well are engaging our community leaders in part of the messaging, some of the messaging. My father is the CEO of the YMCA of San Francisco, and he just sat on a panel with many members of the community last week on this exact topic. And a very popular Bay Area rapper named E40, who I'm sure you're not familiar with, Ron, Aaron may know, was actually on the panel with him. And I thought, wow, this is, the mayor spoke, Kamala Harris spoke. It was a huge sort of cornucopia of influence. But the fact that my dad's face was next to E40's, I thought, wow, this is really a way to get everybody involved. And the messaging was on point, and it was thorough, and it was comprehensive. And I think we could take a note in that we have to be, those of us who are, boots on the ground from all aspects, from academic medicine to community medicine, really need to try to find a unified voice that we can impart on our patients and educate them one-on-one, because it just doesn't seem as if there's going to be a lot of messaging from leadership on a more broad-based level. In addition to our societies, which we hold near and dear, I think that one-on-one engagement and the community engagement is going to be key.
No, I totally concur with what you're saying. I mean, I do see some opportunities here because it is a shock for all of us. I mean, no one expected it. I think within any community, no matter who you are, male, female, any racial, it's just a shock for everyone. And I think everybody's trying to look at his own little world. What can I do better to not be that vulnerable in the future? So I think that maybe give him or her some insight to do a better thing, but we still need to educate them, as you said. And I do believe that we should expect the thought leaders of any community to take an example of what your dad is doing and other places that are doing, to recruit those individuals and to carry the message on and on and on in the channels that the people who are most vulnerable are tuned to. I mean, there is no point to do it in channels that no one do it. If they don't read the Washington Post, I don't care what's going to be written in the Washington Post. So our time is almost up, but if any of you wants to add anything or a conclusion or take home message, please do. Maybe I'll start with Dr. Williams.
Well, thank you, Ron. I really appreciate the fact that you're putting this on. We are at an opportunity, as all of the speakers have highlighted. We certainly have shown a light on the healthcare disparities that we have in this country. We've really had a good analysis about, as I said, the inward-facing and outward-facing underpinnings of it. Now we have to go forward, and we have to try to fix the systemic and systematic racism that has led to this happening to our communities of color. We have to protect the vulnerable, and that's what the United States has been aspiring to. Maybe we haven't been that good at it, but we've at least aspired to doing so. And so I hope that everyone listening will take up the challenge and think, what can I do? Is it the American Medical Association? Is it the state legislature in Illinois? Every aspect of our society needs to take this on. So thank you.
Well, thank you very much, panel, for joining us, taking your precious time. This is a very important cause. we would post it on CRT online. Hopefully we'll have the CRT meeting again next year, maybe with social distancing, but we committed to have it. But I think the message of closing the gap should continue to hammer and hammer and hammer. And I wish we would have metrics to share that we're doing good. I hope that this talk will help us at least on other aspects to make better. So I really appreciate you coming, and stay in touch, and we all hope for good news.